Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. And I'm like in the corner dry heaving.
The gratification you get from going to go digging for that.
Oh, love that. Just got like 5 tweets from that.
See the co-host looking at me.
What's up, guys? Welcome to the Fresh RN podcast. I am Katie Kleber.
And I'm Melissa Stafford.
And we have a guest here that we're so excited to have. We're recording from Houston at NTI, the American Association of Critical Care Nurses. They have a conference every year that is wonderful. Me and Melissa have each been 3 times, and we decided to take advantage of the attendance of a very famous nurse blogger, podcaster that's here, Sean Dent.
Yay!
What's up?
Thank you for joining us. And we're going to be chatting with Sean. Okay, can you give everybody just a short little bio and your experience level and like that kind of stuff?
So I'm a seasoned old nurse of, I'd say, 13 plus years. Sad that I don't know the exact year number. Been a nurse for 13 years. Outside of 3.5 months of my career, I have spent my entire career in the ICU.
Wait, where were you for those 3 months?
Oh my God, orthopedics.
Okay, just curious.
No.
I didn't know that you weren't in it the whole time. Okay.
Yeah, so for 3 months I tried orthopedics and realized how grave a mistake I was.
Okay.
I've worked in every ICU you can think of. If there's an ICU out in the adult world, let me clarify that.
Oh yeah, that's important. Oh yeah, we're talking adult.
Any ICU in the adult world I have worked in, and then about 6 or 7 years ago decided that I wanted to advance my career and went to NP school. Graduated, and now I'm working on my 5th year as an acute care nurse practitioner for a level 2 trauma service that we provide critical care services to all of the ICUs inside of the walls of the hospital, and I care for pretty much every ICU patient you can think of that comes through the doors.
Wonderful. So we wanted to leverage your expertise for our newbies here and talk about respiratory. It's a huge topic, and it's especially, and we're going to mainly, I think, chat from an ICU perspective, but a lot of what we're going to say is very applicable to the floor and the ED. But I wanted to start out with just some basic patho from a respiratory standpoint. What are some of the nailed down points from a gas exchange aspect that a new nurse needs to be aware of?
I'm not going to offend anyone's education. Everybody has taken patho, everyone's taken A&P. Everybody understands the perfusion, diffusion of your lung with your arterioles, bronchi, bronchioles. We're not going to go into that. What I think most nurses forget about the airway is what happens between the outside and the back of your throat. Everything else beyond that, everyone is focused on. Oh my God, they have something caught in their trachea. Oh my God, there's something, they have an infiltrate. They have pulmonary edema, interstitial edema. All of those are absolutely important. But from a basic nursing standpoint, you need to master what's going on from the outside to the back of the throat. And the most important part of all that is, what can the patient do to assist themselves in their pulmonary toileting?
And can you define pulmonary toileting real quick?
Coughing and deep breathing.
Okay.
At its most basic level, can they take a deep breath? Can they cough? And for those of us in the ICU world, can they protect their airway? Mm-hmm. Are they able to stop anything other than air going down their trachea? And can they do that on purpose or by accident? Meaning that there are patients out there, and for those of my hosts here who are neuro nurses, there are many disease processes that affect your epiglottis, the ability for your epiglottis to actually work and function appropriately. Things like quote-unquote microaspiration and paralysis, vocal cord partial paralysis. Those things will affect your ability to quote-unquote protect your airway. So if you have someone who has a neurological process, a stroke, or is weak from debilitation in some way, shape, or form, their pulmonary toileting is going to be affected. And it's your job as a nurse, no matter what level, no matter what experience, and no matter where you work, to be able to master what goes from the outside to the back of their throat.
Oh, I love that. Just got like 5 tweets from that.
Me too. No, I'm just kidding.
I'm like frantically scribbling notes, guys. So great. I love that breakdown. So let's talk oxygen delivery methods. Okay. I think that's something that there's a lot of stuff, a lot of ways that we can give patients oxygen. And I want to go kind of roughly through each one and what are some common mistakes with them? Or maybe let's start out with common mistakes with supplemental oxygen, and then we can talk delivery method. How about that?
Okay. At its most basic level, everybody knows and is comfortable with nasal cannula. That's probably the first device we use. Someone who's having difficulty exchanging oxygen or is quote-unquote hypoxic or low sats, we usually throw them on nasal cannula. And before we go into any of these devices, let's preface this with oxygen is a medication. Mm-hmm. It is toxic. So too much, too fast, or not enough, let's be honest, it'll kill your patient. So you need to take whatever you do to your patient seriously. And if it's something as what you call simple as putting nasal cannula on your patient, just remember, you just gave him a medication. Mm-hmm. So you need to pay attention to what you just did. Nasal cannula goes in the nose. There's different forms of nasal cannula, different types of nasal cannula. You can have monitoring nasal cannula so that you're monitoring end-tidal CO2. We could really go horribly in depth. But at its most basic level, nasal cannula delivers up to 6 liters of oxygen, meaning that it's effective at 6 liters of oxygen. Anything beyond that, you're talking about flow rates and whether or not the amount of oxygen that you're blowing into their nose is actually getting into their airway. 6 liters is about standard, and this is for a standard run-of-the-mill nasal cannula. And I can see the co-host looking at me. Go ahead.
I just want to say it's very important to hear him say that oxygen can be toxic. And there's a lot of nurses out there that'll just throw somebody on 2 liters because it makes them feel good. They're just on 2 liters.
Or they do that to everybody.
Yeah.
Everybody that comes from the ED has 2 liters of nasal cannula. Like,
why are they on that?
Yeah.
If they don't need it, don't let them wear it. And then the other side is too, I think, have you guys ever had to wear a nasal cannula? Like,
yeah,
I did.
Just once for a very short period.
I hated it. It sucked. I didn't really understand how drying that was to my nose. So humidity on said nasal cannula, especially the higher flow rates that you get, is a wonderful thing. Mm-hmm. But, I hated that nasal cannula. And I'm kind of glad I had that experience. It was while I was still in nursing school. But it gave me an appreciation for how annoying it is. Yeah,
and I think knowing that it's also hearing him say that don't give it if you don't need to. And so that also means if they've had it and they don't need it anymore, to freaking take it off. Yes. Like looking to wean. So if you have this like person in the ICU that's on 4 liters of nasal cannula sat in 100%, well, why don't we bump it down to 2? And then let's look at weaning it off. And why are they getting transferred to the floor with a couple liters?
If their sats are 100%.
Right, like why? We don't just want to coast, we want to progress the patient. So looking at as we talk about these devices, when can I wean down and take steps down? Because that's essential, because, sending a patient home on oxygen,
it's actually quite expensive.
And I've tried to facilitate it from the floor. When I worked on the floor, trying to discharge a patient who's never had oxygen before is a nightmare. Yeah, but
insurance hoops you have to jump through.
I mean, if you have somebody on oxygen, it should be part of your plan of care for that day to work on getting it off.
Right, right.
You don't just take a patient on nasal cannula and be like, all right, whatever.
And that's what they are.
Nasal cannula at the beginning, they're on at the end.
Right.
Sometimes they need that, and if they do, that's great. But progress them.
Yeah, kind of like you look at weaning off a drip. Like you want to wean off the oxygen, and it's a medication. Think of that like a drip, like you want to get rid of.
There's a titration order for oxygen sats for a reason. So
Ding, ding, ding.
it's not just there because it's a really cool, pretty protocol. It's there for patient care to optimize your patient's respiratory status and their pulmonary toileting. So I'm going to move on. So that's nasal cannula. Then you have what you can call high flow nasal cannula, and that can be anything from 6 liters up to, and there's a bargaining debate on this one, but you could probably get up to 15. But let's keep in mind, as Melissa pointed out, the comfort level here. So you're blowing 15 liters of oxygen through their nares.
Makes me want to like
yeah. So just stand
I was on two,
just stand outside the room and listen to that. How high and how annoying that is, and then walk in, or better yet, the next time you decide to crank up someone's oxygen level like that, and they're in their nasal cannula, and they're on 6, 10, 12, 15, I would love for you to take it out of their nose, or before you put it into their nose, just put it in your hand. How much is blowing into your hand, or put it up to your face, or for those of us who have hair,
which is not Sean.
which is not I, but just I guarantee you that amount of oxygen will blow in your face as if you were in a car. So keep it in mind. Just because you can do it doesn't mean you should do it. Pay attention to what you're doing and why you're doing it. So.
And you said, what is the lowest setting on that high flow?
So the idea behind the high flow nasal cannula is that you're still utilizing the nares to deliver oxygen, and 6 liters wasn't enough. I don't know who in their infinite wisdom created the high flow nasal cannula, because I don't think it really does a good job. I think it's just a delaying device. So someone who really truly needs that much oxygen, they better have a chronic respiratory problem that we're addressing in a very aggressive manner, because there's something amiss between the oxygen delivery system somewhere in their body.
Well, and I think it's come in handy in my experience as far as if somebody's on a humidified oxygen mask and they need to eat, but they can't go without their oxygen, then I may use high flow to put on their nose while they're eating. But then when they're done eating, it's off and they're back on their mask. So
Perfect example.
That is a really good example. So common mistake with just quickly with the nasal cannula is probably too high.
Correct.
And not humidified.
Correct.
Any other common mistakes with nasal cannula that you guys see? Other than it existing,
it's put on backwards.
Put on. Oh yeah.
it actually goes in their nose.
Yeah, it like cloth down into the
Have
nose.
you seen the cannulas that are sitting in their mouths?
Yes. Or a nasal cannula on a mouth breather. Yeah. So those are some like things to avoid. So make sure you're. So with nasal cannula, to make sure that you're only putting it on when you need to, that you're at the appropriate rate and not too high. And what was the third thing that I just said?
Putting it on correctly.
Putting it on correctly. So, and then when you look at high flow, really looking at if you need it and why you need it, because something else is probably going on. Again, making sure you're at the appropriate rate. And you can't use, correct me if I'm wrong, but I'm like 90% sure, you can't use high flow without humidification. That's just not an option, right?
Well, you can. Yeah.
Technically do it.
Technically you can do it, but once again, as Melissa pointed out, you want to talk about drying out the airways.
My eyes just water thinking about that.
I mean, your patient's lips will crack, they will bleed immediately, and it will mask a true assessment of your patient, because one of the ways you assess your patient's fluid volume status
is their mucous membranes.
Oh my God, mucous membranes are completely bone dry. Is it because of the 13 liters of oxygen going into their nose, or are they truly dehydrated?
So that's a good point. And then, so let's talk about the face mask, and I put face tent too, but I think that's a little more specific to our neuro patients. So we probably don't need to go over that one. But
face tent, we use them.
You do, okay. Okay, so let's talk face mask, and let's say the patient we're at 15 liters of high flow, or now what do we do?
So you have a simple face mask, which there's no titration to it. It's basically just a nasal cannula, but it's a mask. So for the mouth breathers. And it usually can deliver about the same amount of oxygen. Sure, you could probably crank up the flow rate, but you're only going to get so much oxygen. The short answer to all of these devices is they only deliver a certain amount of percentage of oxygen. And we could go into the pathophysiology about it, but room air has 21% oxygen. And every time you give a liter of oxygen, depending on the delivery method, it increases it by 1 to 2%, sometimes 3. And you have to think about the delivery method and how your patient is accepting it. For instance, if I blow 15 liters of oxygen into someone's nose, but their mouth is open the whole time, am I truly giving them 15 liters of oxygen?
Right.
I am not. So that's why you put a face mask on to create a pseudo seal. So rewinding back to now, the simple face mask is just basically nasal cannula just for your face. And it looks like a BiPAP mask, or it looks like a non-rebreather mask or a veni mask, and all it is just a mask that connects to the oxygen tubing, and it's for the mouth breathers. And I guess it's a troubleshooting method for those of us who have been on 12 to 15 liters nasal cannula, and the SATs are not something that you're trusting. So you put them on a mask to see if maybe they truly are a mouth breather. Because if they are a mouth breather and you put a mask on them, you'll have an immediate change. It'll go from low SATs to adequate or 100%.
So simply try a mask. There you
Dun,
go.
dun.
Dun, dun, dun. So if you have that mouth breather and you need to know, but is there any other situation really where the simple mace?
The simple
Do
mask.
you need a little more coffee?
Insert coffee. So any other than the mouth breather, is there any consistent situation that you would utilize a simple face mask?
Oh, that's probably the one I use the least, honestly.
Yeah, simple face mask doesn't have any titration to it, so there's no advantage to it besides it being a mask when it comes to cannula versus mask.
Okay.
You're putting it on their face. Now, it also could be, and I'm thinking of patient-specific issues, patients that have had facial surgeries, maxillofacial surgeries, that need to have an open mouth, or someone who's had their jaw removed from cancer. You're going to have to use a mask of some sort. And it's also not a sealed mask, meaning there's no definitive seal between the patient's face and the mask, meaning it's going to move around. You're not delivering the exact amount of oxygen that you've titrated because there's not a complete seal. So, and that's acceptable when you're using just a simple face mask.
All right, so let's progress.
So the next step is probably what I'd call a veni mask. A veni mask is basically a simple face mask with a dial that you can dial the titration of the oxygen. And some veni masks are titrated by liters, and some are titrated by percent of oxygen. Take your pick, doesn't matter how you want to process that information, but it's basically just delivering more oxygen to your patient. And that mask, some I've seen you can seal, but most you can't. Most it's just, you have a strap around the back of their head, and it's just holding the mask in place. You're not creating a definitive seal. What I mean by seal is that no oxygen can escape between the borders of the mask and the patient's skin.
Okay. So and so for the new grad that's throwing somebody on a veni mask, they hook it up to the wall, crank it all the way up from the wall, and then titrate at the mask. Correct?
Correct. So
No, I was going to say, the ones that we have at our hospital, the dial itself tells you what you have to have the flow rate at on the wall.
Got it.
So if you want to have a 40% veni mask, then you have the flow rate at 6 liters. If you want to have a 50% veni mask, then you turn it up to 8 liters.
So how would the new grad know what percent?
meaning,
What percent to have that?
so it's go low, start low, and go slow
There you go.
for everything that you do.
There you go.
I will caution everybody that outside of standard nasal cannula, if you are upping your game in any way, you better be making a call to respiratory therapy. Because they are the experts, they are the specialists that are going to assist you and augment your therapy.
And if you're on the floor and you're having these increasing oxygen demands, and you were on nasal cannula, now you're on high flow, now we're progressing in this order that we're going, like that is like a respiratory or rapid response kind of a situation. Yeah, progressing.
That is a change in clinical status.
Yeah.
You better be telling somebody.
Yeah, so you're not in your own little silo trying to figure this out by yourself. This is a quickly.
It's a big deal when your patient requires high amounts of oxygen.
Yes.
There's something underlying that
So
needs to be
let's
treated.
go back to basics. When everybody is in nursing school, there's this thing called basic life support.
BLS.
Right? Okay, so what is the 3 letters that everybody has to learn when you want to assess your patient in an emergency? A, B, C. And what's A?
Airway.
So, stick to your basics. And quite honestly, trust your gut.
So with a face mask, hopefully you're able to know if it's telling you how many liters, it's probably, like, because with our other ones being, one thing I wanted to ask, let's say you've got the O2 too low. Is that an issue, like, for these rebreathers?
So we're not, go ahead, Melissa.
No, I was just saying, you're talking about, so like if the mask tells me that I think I have the dial turned to 50%, but I don't have the flow rate at the right.
Correct.
What would happen?
Yeah.
Other than patient assessment and looking at your sats, you're not going to know unless you're comfortable with the Veni mask. So caveat being is that a Veni mask is not something that we traditionally use anymore. It's once again just a stepping stone to either worsening clinical status or improving clinical status. And a Veni mask is not something that you can just get out of your storage room. It's usually something you got to get from respiratory, at least in my experience. It's either you have nasal cannula, high flow nasal cannula, you have a simple face mask, or you have a non-rebreather. And the non-rebreather is there usually at the bedside or on the wall, at least in my experience. And now we're talking about ICU versus floor nursing. So once again, if you're going from a nasal cannula to a high flow or anything above a nasal cannula, you better be recruiting help, especially your respiratory therapist. If not, your nursing leaders, your nursing management, the seasoned nurses, so that you can get their input. Because once again, if you're needing to increase the oxygen delivery to your patient, you better be asking why.
Good. Okay. So now let's go to CPAP, BiPAP situation here, which I've had on the floor before.
We skipped one.
Oh, did I? The face tent.
So, we skipped 2 then. So a face tent is just something that most people use post-operatively, or they use them in post-surgery patients. I actually used one a couple weeks ago on someone, and it had everything to do with their clinical condition, which I won't share. HIPAA. But a face tent is basically just a simple face mask that sits underneath their chin, and it straps to the back of their head to hold it against their face. And I sometimes, maybe Melissa will know this term, it's sometimes called blow-by.
I was going to say the same thing.
It's sometimes called
like
blow-by.
oxygen.
It's utilized a lot in the PACU in recovery for patients who are waking up from anesthesia, who can protect their airway, who are awake, who are alert, who are coughing, but they're just kind of groggy. And every once in a while their sats drop, or they're laying flat because they can't sit up because of a surgery. So they put them on some supplemental oxygen so that there's nothing invasive. It's not covering their face to scare them, and it's not in their nose to dry out their mucous membranes. And I mean, it's just something to augment them while they wake up from anesthesia. So face tent is not something that you're traditionally going to see unless you're in a specialty area. Yeah,
and we've seen it in neuro with specific like tumor removal and that kind of stuff, or nasal surgery kind of thing. I don't think I've seen it in any other. So
I kind of feel like, I don't know if you were thinking the same thing, but I want to talk about like the humidified face mask. Because we talked about the simple face mask, the Veni mask, even a rebreather mask. Those are all dry oxygen delivery devices. If you have somebody who has a lot of secretions and you give them continued dry oxygen, they're going to wind up developing mucus plugs. So I like cement, and it's nasty, y'all. I
think I'm dry heaving.
Oh gosh, that's like my
Can we just talk about how gross the word mucus plug is?
It's so so gross.
I love it.
It was so bad for me one time. I was in the ICU, and there's this guy I was really trying very hard to keep him from getting intubated. And I was very, talk about aggressive nurse, pulmonary toiling. I was gagging in the room, which one of the respiratory therapists walked by, and I'm like, please, Carrie, please save me. Please save me. And she came and she was laughing, and I'm like, I have to leave the room.
Like, you know how every nurse has that thing, that specific thing that really grosses them out? For me, it's sputum.
Really?
Yes.
Sputum is
sputum.
I love it.
I love sputum. I get like tingles when you NT suction someone.
That is exactly.
And you
just
have that. Love that sound.
I hate that.
Absolutely like the gratification you get from going to go digging for that. Now, let's keep in mind this is not comfortable for a patient anyway, shape, or form.
No.
Not at all.
No.
And
Nor is it comfortable for me.
You know, all the nurses have a very dark sense of humor, but that noise you can hear from the hallway.
You can.
You can hear from the depths of your soul.
80% of ICU nurses out there will be like, yes!
Oh, it's great when they sound better afterwards, but in the process, like Carrie was in there, she's suctioning, and she was like, oh, look, some more sea creatures. Let's get back to SeaWorld. And I'm like, oh.
And I'm like in the corner dry heaving, like, I can't, like this, like, I will, you know how there's things like, I don't want to, like, little procedures, like, I don't know why I hate
You bargain
like,
with your
I hate doing,
true.
I hate discontinuing art lines, and I hate trach care. I will bring you cookies tomorrow.
Do you like doing wounds?
Oh, yeah.
So then we would work great together.
See, I love.
I'll give you the wound.
Give me
stuff.
the
I'll
nastiest,
take all your A-lines and I'll just,
pussiest wound. I will do that. But,
yeah, no way.
but do that trach care for me, and we are. But I'll go get you cupcake from downstairs, homie.
Yeah.
I don't want to touch that tray. I hate. Okay.
Anyway,
we digress.
It's a humidified oxygen delivery.
Yeah, I think at any time that you can give humidified, you should, no matter what.
Even on 2 liters nasal cannula.
Absolutely. Because you're bypassing your body's natural ability to humidify air. Remember, you have those hairs in your nose, and in the back of your throat, you have more moisture in the back of your throat. That is your body's natural way to humidify air. And when you blow air through that passageway, you're bypassing that. So you need to give the patient humidification if you're going to give them oxygen. So, and I think Melissa makes the greatest point of all, is that I still believe to this day that anything that we do to our patients, you should try and experience just once.
Yeah. Although I don't really want to experience putting a suture in someone's, whether we just took out their EVD or putting in an EVD. I'm good.
This is good. Yeah,
I'll help you experience NT suctioning if you want.
Yeah, let us know.
Or what is that? A nasal trumpet? Oh my god.
Yeah.
I don't know if y'all have seen. You love it. It's so funny.
Love it.
Like putting in a nasal trumpet, y'all, is so barbaric. Can you just?
True.
Can you explain a nasal trumpet to people?
For someone who has sleep apnea, who has a history of obstruction, so it actually stops the tongue from dropping in the back of the throat. And for someone who may have a deviated septum or things like that, all it does is create a clear path. And for someone who is getting frequent NT suctioning.
So, y'all, I'm going to put a picture of a nasal trumpet in this show notes. And that, like, the first time I was in, because I didn't use them until I was in the ICU setting. And then the first time, like, my preceptor, Elizabeth, pulled one out. And I was like, Jesus, we're going to put that in the patient's nose? And then she got a ton of lube. And I was like, I was horrified. Like, But then
the patient doesn't enjoy that.
But yeah, and it was, but it helped. We had to do a bunch of suctioning, and it made that significantly easier.
It minimizes trauma.
It does. No matter
Give
how.
somebody some serious nosebleeds if you're constantly doing that.
Oh yeah,
Yeah.
Your patient's coagulopathic, you're in trouble.
Yeah. So, I forgot about nasal trumpets. Okay. I feel like I missed something else before CPAP, BiPAP. What did I miss?
Non-rebreather. We just kind of skip right over
Oh,
non-rebreather.
my
Non-rebreather
bad.
is probably the most important one of all.
Let's go there.
And the delivery that will deliver the most oxygen you can give a patient before you put them on a BiPAP, CPAP, or the ventilator. So anything above a non-rebreather is called non-invasive positive pressure ventilation. And that's some form of, I'm pushing air into your lungs. I'm not just throwing oxygen into your nose or into your mouth. I'm pushing air into your lungs. And a non-rebreather is the last step before that.
Okay.
And it delivers hopefully 100% pure oxygen at anything above 15 liters. For those of you that know what the oxygen looks like on the wall, you're just basically going to turn the dial up until the dial can't go anymore, and then keep turning until you hear that noise that is deafening. With that, you turn the oxygen that high. And a non-rebreather is, once again, it creates a pseudo seal between the patient and the actual device.
Hence non-rebreather, right?
And the most important part, which Melissa's probably going to allude to, is that if you don't deliver the proper amount of oxygen, the non-rebreather actually will not only give you the oxygen you want, it'll actually starve your patient of oxygen because you're basically suffocating them. So if you don't put the non-rebreather up appropriately, and the way you'll know is that there's this really cool bladder that's supposed to be full of oxygen, and it's supposed to be full. And if that bladder or balloon or
bag,
whatever you'd like to call it, if it doesn't have if it's not full, meaning it looks like it's distended, then you have not turned up the oxygen high enough.
So like, on the plane is, even though the bag's not inflating, the air is flowing. We need the bag inflated.
And usually it's one of those aha moments. If you've never touched a non-rebreather before, and you can remember that balloon, that bag, that bladder has to be open and full, the minute you turn the oxygen on and you turn it up to 15 liters and you can hear that deafening sound on the wall, but the balloon is still not full. The minute you turn it up, you'll see that bag start to fill up, and you'll know immediately if you've given the proper amount of oxygen. This is before you even place it on the patient's face. You don't want to do this while it's on the patient. So that's a non-rebreather.
Turn it on, then put it on.
Yeah.
Yes, and just crank it up until basically the dial can't turn anymore. Just keep turning until you come to a hard stop. That's when you know you've given enough.
And again, and hopefully, especially if you've never done this before, you got a respiratory therapist next to you, really, because you think about, and you think about, your nursing school and everything. So respiratory therapists have 2 years of school just with the respiratory system and devices, if not more, because you actually can get a bachelor's in that, in respiratory therapy. That's not the actual name of it, but like you can get a bachelor's in that.
There's advanced certifications
too. So leverage their knowledge while you're messing with these devices, because you can't afford to get utilizing these devices wrong. Like, you just can't afford to do that. So if you're like guessing, and if you're getting to the points when these scenarios we're talking about it is essential to have that person next to you that has been doing this and knows all things inside and out respiratory, walking you through this.
Yeah, you need to put your pride in your pocket.
Yes.
You need to utilize your resources. And one of the things that all of my respiratory therapists have a problem with is that most nurses just call them RT instead of actually calling them by their name or learning their names. You got to learn their names and who they are, and Carrie. Be willing to learn from them because they can teach you a great deal. The only reason why I'm comfortable with respiratory the way I am is that when I was a new nurse in the ICU, I Velcroed myself to a respiratory therapist.
Oh my gosh!
For the first 2 years, I worked in the ICU because the docs weren't the most teaching-oriented kind of physicians, but the respiratory therapist was. So all the advanced stuff that I know, that I'm comfortable with, started because a respiratory therapist taught me.
Yeah, and like the respiratory therapist, especially in the ICU setting, they're there. I mean, I know they don't have 2 patients that they're taking care of just that day, but where they're located is where you are, and if they're suctioning your patient, doing a vent check, doing whatever, and utilize them while they're there. It's another person on the healthcare team to build rapport with, to learn their name, to ask how they're doing, and then show that their knowledge is valuable, because whether or not you realize it is, and they can so save your butt.
Oh my goodness!
Oh my gosh.
They're wonderful, wonderful resource to have.
Yeah.
Wonderful.
As an advanced practice provider, I talk with my respiratory therapist every day, all day, throughout the day.
Cue 5 minutes.
Yes. Like when I walk into the unit to assess the floor, the first person I talk to is the charge nurse. Second person I find is respiratory therapy.
Mm-hmm.
I talk about everything that's been going on overnight, and I ask, what have you done so far, and what are we doing when it comes to weaning parameters and what we're doing with our vented patients and patients that need oxygen therapy. So.
All right, I'll get off my RT soapbox.
All right, so
Very
BiPAP,
pro
CPAP?
RT. BiPAP and CPAP are the non-invasive positive pressure ventilation, NIPVV. PPV. Jeez.
Sounds like a disease.
They
You got PPV?
No.
yeah, no kidding.
Sorry.
If you're using these two therapies, they better have a chronic problem, or you better have involved your providers, because this is advanced. And you have to have some. So let's just talk about basic knowledge. CPAP versus BiPAP. It creates a seal between the patient and the mask. So air should not be escaping between the edges of the mask. That's the most important part.
And the alarm is really annoying if it does.
Yeah. So, you got to keep in mind, for someone who, like me, who has little facial hair and no beard, it's not a problem. But someone who has a beard, has a lot of facial hair, who has some sort of abnormality with their facial structures, CPAP and BiPAP are going to be quite challenging because you have to have that seal.
And if they have an NG tube or a feeding tube in, I mean, you won't be able to get a perfect seal, but you need to know what is adequate and what is not.
You know what? Oh, I saw, online, a respiratory therapist had posted a thing about trying to get a seal on a guy with a beard. You know what they did? They put Tegaderm over the beard. I mean, the guy's out of it. And it was, a pretty hairy one, so that they could get a seal on top of it, which I thought was a really interesting way to do that. You get clippers.
We have clippers on.
Yeah, if you get to that
unit,
point.
Forget it. I'm sorry. You're probably going to be upset that I trimmed your beard, but
You need
trying
oxygen?
to save your life.
Yeah. Well, and the other thing is, it's not always about making the mask tighter, because you can cause pressure sores. And I have seen pressure sores from putting on a CPAP or BiPAP mask too tight. I mean, especially across the bridge of the nose. That's probably.
Oh, yeah.
But, I mean, it's the masks generally have a pillow of air around them for a reason, and it's to offer cushion.
Yeah.
They're rubbery, so that they're supposed to offer that seal, but you can't just go in there and just be pulling strings and making it as tight as possible.
Yeah.
That's just bad.
Yeah. Sorry. I digress. Yeah.
So the only difference between CPAP and BiPAP, and this is just basic of basic, is that CPAP is continuous, so continuous positive airway pressure, CPAP. And BiPAP there's bi-levels to it, bi-level positive airway pressure. CPAP means that there's a certain amount of pressure that's given no matter how the patient, whatever the patient's doing. So 5 going in, 5 going out, 10 going in, 10 going out. Doesn't matter. There's always the same amount of pressure no matter what the patient is doing or not doing. With BiPAP, you can actually titrate what goes in and what goes out. So if someone can breathe in 10, but they only need 5 going out, and that is very titratable and has everything to do with their pathophysiology and their clinical process, which we will not go into because that could be a whole nother episode. But at its basic level, CPAP and BiPAP. CPAP is continuous, which is what usually people go home on who have obstructive sleep apnea. And you have the nasal mask versus the facial masks. Once again, you can look that up online, pretty self-explanatory. And all it's doing is keeping their airway open.
Mm-hmm. I have a really good, I didn't write it, but I found one of a really good differentiation blog post about CPAP versus BiPAP. So I will put that in the show notes so you guys can check that out.
Yeah, so don't bog your mind down on CPAP, BiPAP. What you need to understand between those two things is that now we are wanting to deliver higher levels of oxygen saturation. So remember, the nasal cannula, simple face mask, all the face masks up to CPAP and BiPAP, there's no seal. So even though I'm giving 15 liters, 18 liters at 100% FiO2, I'm probably only actually giving them 10 because there's air escaping out of their mouth. There's air escaping around the seal for one reason or another. Whereas with CPAP and BiPAP, I can be fairly confident, fairly confident that what I have set is what they are getting. So that's the big difference. CPAP and BiPAP, your red flags better have gone off because they either have to have a chronic respiratory condition of some sort, smoke or COPD, let's not go into the details, or they had a respiratory problem to start with that is either gotten better or worse.
And then let's get to the big kahuna.
CPAP and BiPAP are jokingly in my world called intubation delay devices.
Yeah,
really
I think
they
it's a good
are.
way to look at that if you're progressing to that point.
So a CPAP and a BiPAP, and if we're going to be honest here, anything above a high flow nasal cannula is a bridge. It is a bridge therapy to figure out how to fix the underlying cause. All it's doing is making you feel better about the numbers on the monitor. It's not fixing the problem. I can give my patient 20 liters high flow nasal cannula. I can throw them on a non-rebreather. I can throw them on a simple face mask, and whoa, stats went from 92 to 99. Success! But it's not going to stay that way. It's not sustainable. It is bridge therapy so that you can figure out what to do to fix the underlying problem. Do they have a pneumonia? Are they fluid overloaded? Are they having a heart attack? The list is endless. You're going to have time to go fix the underlying problem. And that could be something as simple as making a phone call to your provider, talking to your charge nurse. It's so that you can bridge them to wherever they need to go or whatever they need to get. So if none of those bridges work, the last ditch effort or the last option that we have in our clinical practice is invasive, which is mechanical ventilation, which is intubation, which is invasive positive pressure ventilation. So instead of non-invasive, it's invasive. And it is a direct line of communication between the patient and the oxygen delivery system. So there is a plastic tube in their trachea. And that is when you have complete control. You have 100% complete control over what is delivered to the patient. So there's no bartering, there's no questions as to if I'm giving 50% FiO2, is the patient really getting 50% FiO2? If they are intubated on a mechanical ventilator, or they at least have an endotracheal tube, you are 100% giving them that 50%. And I don't know how in depth you want to go with mechanical ventilation, but
because we can go really in depth, but I think that could be its own episode, really. Maybe just a couple common mistakes the new grad. Like I've seen, learning vents is very overwhelming.
It is.
Okay, that's another time to really utilize that respiratory therapist. But I've seen the vent goes off, respiratory is nowhere near. The new grad's just hitting a supplemental O2.
Yeah,
and it's like, wait a minute.
100% O2. Don't. Yeah. So if you're hitting that more than once or twice, you better be calling somebody. Some of the, I guess, let's just talk about some basic things. Is that think about what's going. So start from the machine and work your way to the patient. If the machine is alarming, or if the monitor is alarming, look at the machine. Is there something on the machine that doesn't look right? And you as the nurse may not know that because you're new, so you grab the respiratory therapist, you grab a seasoned veteran. Because it sounds crazy, but most of the ventilators out there are touchscreen. And this sounds really simple, but it's important that if something is obstructing the screen or touching the screen, the alarm's going to keep going off, and you're actually the mechanical ventilator will stop delivering oxygen because the machine feels something's wrong. So it could be something as simple as there's tubing touching the screen. So
and sometimes it's always that kind of stuff. So this thing's not connected the way it needs to be.
The KISS principle. Keep it simple, stupid. Don't.
Dwight.
The thermometer, the heater, the temperature probe pops out of the hole. Then you have a leak in the system, and it's alarming.
So looking at the circuit from the machine to the patient, is there a kink somewhere? Is there a kink in the tubing circuit? Is there a kink in the ET tube?
Did it pop off?
Is there a disconnection somewhere? And then, is the patient coughing? Do you need to suction them? Do you need to suction inline suction in the ET tube? Or do you need to just, clean out their mouth and use a Yankower?
And make that...
So, if all those things don't work and you've given the supplemental oxygen, you have better called somebody by that time. So, that's about as basic as I would get.
Yeah, I think that's good. With the vent. So one of the things is if you're getting an alarm, don't just hit silence. like an IV pump, and
No.
no, it's like you really got to see why is this alarming, and there is that option, and you'll see that the provide O2 breaths, I think is what the button usually says.
It's 100% oxygen. So you give 100% oxygen for 2 minutes.
Yeah, and so it's like you can't just, oh, it's alarming, I'm going to hit that. Like we got to investigate the cause of the alarm before we think about
So remember,
fixing it.
We said at the beginning of the episode, oxygen is a medication. It is toxic. So you keep bolusing them with 100% FiO2. It's kind of like bolusing them with a vasopressor.
Yeah.
Okay.
Oh, that makes me shudder.
You need to figure out why.
Yeah. You can't just like blindly do that until alarms go away. We really got to be diligent in figuring out the cause.
Can we take just a minute to talk about the fact that the SAT monitor is not the end-all do-all to respiratory?
Yes,
Great
I think,
segue.
I want to go into a segue of the SAT monitor. I think because we get so used to that being live and die by that O2 SAT, when there's so much other things that can tell you about the respiratory status of the patient and more reliable. And so I want to talk respiratory, like we're not talking about not living and dying by that number, and then how do we know that number is accurate? And that kind of stuff.
I would probably view everything in respiratory the same way I would view all of your other things when you are assessing your patient. Check the patient first. Forget about the monitors, forget about the equipment, because there's always a malfunction. There's always a problem with monitors. Everybody has different views of the monitors, but at the end of the day, the monitor is not perfect. What you need to rely on your assessment skills. Okay? Quickly, I would look at the patient and their work of breathing. If we're going to talk about anything when it comes to respiratory assessment, is how does the patient look? Are they in distress, or are they completely comatose? I always joked, and it's something that I've done online before, is that we are masters in the middle. We love to master the middle. Our patients need to be in the middle. Patients cannot be at the extreme. We don't like when a patient is completely comatose. We don't like when a patient is so irate and agitated that we can't keep them in the bed. If you're at either one of those extremes, you better figure out why. Maybe you know why for underlying causes, but we're talking about respiratory. If they're breathing 50 a minute, you better be doing something to intervene. And if they're breathing 5 a minute, you better be doing something to intervene. Don't treat a number. Don't treat a monitor scale. Don't treat an ABG. Don't treat anything that is printed off. Treat the patient.
And that includes pulling their covers down and looking and seeing how hard they're working to breathing,
They're
using accessory muscles. Are you actually counting respiratory rate and not just looking at the number on the screen? Because that's not always accurate. And are you actually looking at the patient and counting how many times a minute that they are breathing and not just writing 18?
And I don't want to. I know that we're pressed on time, and I know that there's so many other things we talk about. I don't know, and this is my fault that I don't remember, but in basic nursing school, did we go over the oxyhemoglobin curve? Do you remember that in basic nursing school?
Oh,
If you don't, that's okay.
I don't.
So then I would look that up, and that has everything to do with PaO2, SaO2 versus SpO2. And if you take home anything from this episode, is 2 things. Work of breathing, what do they look like? And that your SATs are the last thing to go. So if you are treating a low SAT, you are behind the 8 ball. And that's the way you should treat your patient.
It's kind of like how we've talked about in neuro. If you're just waiting for pupillary changes, you're waiting too long.
Yes.
There's other things, other clues in the assessment that should let you know before that number, or before their pupils go, before that assessment thing changes, before that O2 SAT changes. So yeah, it's important to be diligent and looking at all of the pieces of the puzzle and not just that blue number on the screen.
Yeah. Treat the patient first, and then troubleshoot your equipment.
So I was going to ask you to step on your respiratory soapbox, but it sounds like you
Kinda
were already there.
did.
Is there anything else? So I'd like to end to say, you've got all the new grads in the United States right in front of you, and you're stepping on a soapbox in front of them. What do you want them to know from a respiratory standpoint? But in addition to what you just said.
Rely on your physical assessment skills and your basic nursing knowledge. There isn't a piece of equipment or new technology out there that's going to trump your gut and your assessment skills. Because if you feel in your gut that something is wrong, act on it. the worst thing that happens is that you were wrong and the patient's fine.
Right. That's the worst case scenario.
The best case scenario, you just saved their life. So
Literally
that's the way
save
to-
somebody's life.
Yeah. So rely on your physical assessment skills. Something as simple as sitting them up in bed will improve someone's SATs by almost 10%. If you just sit them up and lower their diaphragm and have them to deep breathe and cough. Deep breathing and coughing, pulmonary toileting actually matters.
Incentive spirometry. You don't just leave that order on your order thing.
Correct.
That is so important.
Incentive spirometry is not an inconvenience. It's actually exercise for your lungs.
Yes, it's so important, and having those patients, like, actually educating them on it and not just sitting it on the bedside table, telling them how to use it. You got to use this 10 times an hour. You're watching TV, you need to do that every time there's a commercial 3 or 4 times, and making sure that they're doing that. And part of your job as a nurse is being diligent in that compliance.
As an APP, I support that every single day. I always ask my staff and I always ask my patients, how many times have you done that? And every time you walk into the room to do something, even if you're going to give them a drink of water or a new pill, hey, show them what you're doing on the incentive. There's no such thing as doing that too much.
Yeah, and it almost reminds me of hand hygiene, right? Like, it's something that you need to do very consistently and very diligently to avoid those major complications, because it seems like something that's so small, but you can make
no
or
bones
break
about
thing.
it. It's hard for patients, but that's your job. You're advocating for them, and sometimes you're going to be the bad guy or bad girl because you're putting them through something that hurts, because it's going to make them better.
Sometimes the most loving and caring thing we can do is tell someone no. And tell them or make them do something they don't want to do. And just because it doesn't feel good doesn't mean it's bad. Yeah. Sometimes you got to do the thing that you don't want to do.
I actually love being the bad guy.
You can blame it on me. I'll kick everybody out. Blame it on me.
I've actually done that many times.
Yeah.
When the new grads and the new nurses are like, well, they're not going to like that. I'm like, you can blame it on me.
Yeah.
Just tell them the nurse practitioner made me do it.
Yeah,
I have
exactly.
no problem with that.
Well, thank you so much for being here today, Sean. We appreciate
Thank you for inviting me.
your
This
knowledge.
is fun.
Yeah, this episode could have been like 4 hours long, I swear. So thank you guys so much for listening. I'm going to have show notes where I'll have a link to that blog post. I'll have a link so you can check out Sean's website, his social media handles, his podcast. He's also a podcaster, so he's got, 3? 3 podcasts? Is that where we're at? 4?
Somewhere.
I don't know. Just search Sean Dent on iTunes. So thank you guys for listening, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got